In this next section, I'm going to discuss how to avoid unnecessary burdens in your birth. Now, remember that a burden is something that causes us anxiety, strain, misfortune, not good feelings. So there's a lot of things that can happen in birth. We know birth is unpredictable, but there's a lot of things that could be avoided. So I want to teach you guys and share with you the truth about where a lot of these burdens do come from when it comes to birth. Well, I read a quote once by Dr. Stu Fishbein. He is from Birthing Instincts. You can look him up. He is a wealth of knowledge and a lot of resources that he has are extremely helpful and were helpful for me when preparing for birth. But he was a previous doctor or OBGYN who now is a midwife. He primarily works in the home birth community. And he said, when you end up meddling with birth, you end up needing technology. So we've talked about physiological birth. So what happens when you start to mess with this process? We know God designed our bodies to have hormones that kick off this physiological process, and that all of our hormones are interconnected and create contractions. They help create these surges that will eventually push the baby out. It is all very purposeful. So what happens when you start to intervene and change the physiological process of birth? Now, that is what I want to share with you so you can understand again how some of these burdens or complications, a lot of times traumatic stories that you may hear about birth, how these happen and why they happen. In the birth community, there's something called the cascade of interventions. Now, this is a series of cause and effect outcomes that happen during birth. Now, we know the C-section rate has increased over time. If you look at C-section rates over the past 100 years, it has significantly increased. And now 1 in 3 women will end up with a C-section. So why is this? What has changed? And I can tell you the biggest thing that has changed is the use of technology, which, don't get me wrong, technology has its time and its place, but the use of technology and interventions within the birth process, things like inductions, have become extremely popular. So the correlation between the two is undeniable. I'm going to talk you through a typical cascade of interventions and what this looks like. So the beginning of the cascade of interventions, a typical example would be you're giving birth in a hospital, and again, typically under the care of a doctor or OBGYN, you will have more routine things like ultrasounds, just more testing done at the end of your pregnancy, which a lot of times can lead to false information, or I shouldn't say false information, just information that leads to outcomes that may not be completely necessary or evidence-based, meaning that there really is no proof to show that this would help the outcomes. But that is the first thing, is just more interventions during pregnancy will likely lead to, let's say, the need or a doctor saying there's a need for an induction. So we'll start with a mother being induced as the first intervention. And inductions alone will increase your risk of having a cesarean section up to 33%. So the main reason that this causes cesarean is because it completely changes the physiology of birth. Now, if you go back and you listen to the module on birth physiology, we talked about all of the hormones and that physiological process that goes on. So if you start labor with an induction, which is not using, natural hormones, these are synthetic hormones, like Pitocin, for example, it completely changes the physiological process of birth. So that's the first problem there. As of 2020, statistics show that induction rates have increased from 10% back in about 1990 to 43%. And 1/3 of those inductions are actually even elective. So these are moms that are just deciding that they want to be induced. Now, this is the first intervention, or I guess I could say kind of second intervention. First intervention is a lot of testing, a lot of monitoring during pregnancy that may lead to the need or supposed need for an induction. Now, before I go on to the next intervention or what that cascading effect looks like, I want to talk about common reasons that women are induced in the first place. The first reason a lot of women are convinced they need an induction is due to a supposed big baby. Now, I mentioned that before an induction would be a lot of testing, things like ultrasounds. And the ultrasound is going to be what would show that your baby is measuring very large. Well, when it comes to big babies don't really change birth outcomes. But fear definitely can change the birth outcome overall. You put a little bit of fear into your mind that your body is not capable of birthing your child, then you will likely choose what you believe is the safest option, which will be maybe an elective C-section or whatever your doctor is telling you. But that fear can definitely change the outcomes. Big babies are misdiagnosed all the time. Generally, actually statistically, it's 50% of the time. So 50% of the time when you get a big baby diagnosis, there's a 50-50 chance that it is incorrect. When it comes to big babies, one of the biggest concerns with that is shoulder dystocia. And this is when the shoulder gets stuck and the baby is not able to come out. And that's generally the biggest concern when it comes to the doctors have, is that big baby is going to equal potentially baby gets stuck or there's going to be a shoulder dystocia. So this is what you need to know about shoulder dystocia. The chances of your pelvis actually being too small to birth your baby vaginally is about 0.004%. That is 1 in 250 pregnancies. So keep that in mind. I hear all the time that people had to have a C-section because their baby was too big, their baby got stuck for whatever reason, which I will discuss in this module. But the chance of your pelvis, your actual anatomy, the way God made you, of being too small and you not being able to birth your child is extremely small. The risk of shoulder dystocia increases by 7 to 14% if the baby is more than 9 pounds, 15 ounces. However, this can occur regardless of how big the baby is. A shoulder dystocia can happen even with very small babies. And in most cases, a skilled provider should be able to resolve the issue when you're giving birth. They should be able to identify that there is a shoulder dystocia and help you birth your baby. This is where being able to move freely can be extremely important, because if your doctor or midwife sees that there's, the baby is stuck, due to shoulder dystocia, there's different positions and things you can do to help get the baby unstuck or come out. Going right along with this would be epidurals will decrease your mobility. So that alone, having an epidural where you can't move and you're stuck, and typically with an epidural, you'll be pushing on your back, that will increase your risk of having a shoulder dystocia. So something to think about if you are considering an epidural and you're trying to decide what is in your birth plan, know that if you have an epidural, you're gonna not be able to move, and there's reasons why you might want to be able to move. The next reason that women are commonly induced would be because they are overdue. Now, in America, we go off of a 40 weeks gestation as our estimated due date. And when you look into how due dates are calculated, it's pretty interesting to see that other countries even go off of different due dates. Other countries even go off of up to 42 weeks as the actual due date for baby. As far as how due dates were created, in 1744, there was a professor from the Netherlands who was named Herman Boerhaave. And he explained how to calculate an estimated due date. And this was based off of records of about 100 women. And he figured out to estimate the due date, you would add 7 days to the last period and then add 9 months to that. However, he never explained whether you should add 7 days to the first day of the last period or to the last day of the last period. So this would leave a lot of variation as far as what the due date should actually be. So I would definitely be considering this and would ask my provider about what the true risks of going past your due date are. Again, knowing that it really is not a exact it's an estimate. It's not an exact date. A lot of people call it a guess date because anywhere from really 38 weeks to 42 weeks is very common for a baby to be born. I know some of the risks for having your baby in utero for too long can be a risk of amniotic fluids starting to decrease, the placenta starting to degrade, and also higher risk of preeclampsia. So just make sure you have this conversation with your provider and trust your gut. If something is feeling off to you and you don't know or don't feel like there's a reason that you would actually need to be induced because you're past your due date, then you can definitely decline an induction for that reason. The last reason I will talk about as far as why women are induced would be for convenience. And this can go either way. A lot of women have elective inductions. They choose to be induced for different reasons, and doctors will also push for inductions for their convenience as well. If you look up the induction rates throughout the year, you will see a pretty dramatic spike around major holidays. Holidays like the 4th of July, Thanksgiving, Christmas. They actually call the end of the year induction season for that reason, because a lot of doctors don't want to have to be working on the holidays, and vice versa. A lot of moms would rather, if they could just induce, they would rather do that. So switching back to the cascade of interventions, I just discussed what the common reasons or some of the common reasons are that women would get induced, which is really that first intervention that happens in labor. So after is induced, they will likely have very strong contractions due to Pitocin. And Pitocin is the synthetic form of oxytocin. We know oxytocin will create contractions. So Pitocin does the same thing, only they're typically much stronger. So for a woman to be induced and have Pitocin and start contracting, they, generally speaking, will start to need pain relief because the contractions get so strong. And again, this is just a common example. I'm not saying this is what happens every single time that a woman is induced with Pitocin. This is just a common example of what the cascade of interventions looks like. So we have strong contractions now due to Pitocin. So you'll need some sort of pain relief, which is a lot of times very routine and common to see an epidural given. So an epidural will be given to the mother to help relieve the pain. At this point, when an epidural is given, it will usually cause contractions to slow down. So contractions will slow down, and a lot of times when contractions slow down, that means your labor may stall, and it's also going to slow down overall. Your progress may start to not really go anywhere or as quickly once you get that epidural. So when that happens, a lot of times time will go by and doctors will start to say, we need to get things moving, because when you are giving birth in a hospital, it's just a known fact that they're on a little bit more of a time schedule when it comes to getting women in and out. So because things start to slow down with the epidural, there's a need to get contractions going again. So to get that oxytocin going again, they will have to administer more Pitocin. So they will up the Pitocin to increase the contractions again. And what's not very ideal about this situation is that although you may not be able to feel the contractions at this point because you have the epidural, your baby can feel everything. So the contractions are becoming very intense again due to the epidural. And a lot of times it will cause fetal distress. So you'll hear, I was in labor, all of a sudden my baby started to become in fetal distress. So this is a common situation that happens. And when there's fetal distress due to those contractions, so think about it, your baby is just getting squeezed and compressed every single time. It actually, Pitocin will also reduce the oxygen that they're getting as well. That's when you will hear the need for emergency C-section. So here we are now. We have the induction, the interventions that happened, one cascade after the other, after the induction. And now the mother needs surgery. They need an emergency C-section to get the baby out. So this is very common. It sadly it's just a very common situation. If you know anybody that's had a baby, you probably know someone who has gone through this situation. They may not know that the reason that their birth ended that way was due to the interventions, but that is likely the cause. Again, I'm not saying this is for every person. This is just statistically, we know C-sections are very common, and the correlation between the interventions that are given at a hospital versus, let's just say, someone having a home birth, it's very unlikely for all of these. Well, these interventions would not happen in that situation. So things and the outcomes will look a lot different in that situation. Again, our bodies know what to do. So this is going back to, if you change the physiology of birth, outcomes are going to change. I will just comment on this as well, because this is a part of the cascade of interventions, is when you have a C-section, a lot of times, you can request it to be different if you have a C-section, but you will be separated from your child for a doesn't have to be a long period of time, but there's usually some sort of separation between mom and baby after a C-section. And this is so important because when you're separated from your baby, it's also changing the hormonal response inside of you. And we know that not only does oxytocin um, create those contractions, but oxytocin also is the hormone that initiates breast milk. So if you are separated from your baby for whatever reason, you are impacting your breast milk supply or could be impacting your breast milk supply. Again, it's not an always, but it's very common for women to have more difficulty when it comes to breastfeeding with their supply if they have a C-section. Research actually does show as well that having a home birth increases your likelihood of successfully breastfeeding for at least up to 6 months by 50%. So this is very important. I know for a lot of moms, I hear a lot of times that, oh, my breastfeeding journey didn't go exactly how I wanted it to. I wish it would have been different. And I'm here to tell you that it can go different. And it a lot of times has a lot to do with the birth process. And this is not to make anyone feel bad if they or feel shame if they have already given birth and you're realizing, oh wow, the cascade of interventions happened to me. This is why breastfeeding didn't go very well for me. This is to empower you and to give you the information and the truth about why that happened so you can change the outcomes. You really do have control over what happens in your birth. And I will just say for me personally that this is why it's one of the reasons why I chose to have a home birth, because I knew that my chances of not having interventions and this cascade happening to me would be much less likely. And the outcomes that I wanted for me personally would be a lot easier to achieve in that setting. This is not to say that you cannot have a successful birth with no interventions and have a successful breastfeeding journey in a hospital setting, because could not be farther from the truth. You absolutely can still have those things without having a home birth, because I understand that home birth is not for everyone. I just share my experience to help people understand why people choose to go that route, or at least some of the reasons people choose to go that route. But again, it goes back to, if you have the truth, if you have the information that you need to make educated decisions, you can have whatever outcome you want in any setting you want.